Hello everyone, welcome to this Convergence Science Network event, the Australian Bionic Eye, the people behind the technology. It's wonderful to have so many of you join us. I'm Luan Ismail, the convener and executive director of the Convergence Science Network, and I would like to acknowledge the traditional custodians of the land on which I am located, the Wurundjeri people of the Kulin Nation, and pay respect to their elders past and present. I think it's true to say that there's never been a more exciting time in the biomedical sciences. It's undergoing a revolution as we speak. The rapid advances in knowledge are complemented by new technologies and tools, and importantly, by the advance of the convergence paradigm. That is, teams from diverse disciplines working together in research agendas that are problem-focused and solutions-oriented. These advances have given rise to research that was only a few years ago unthinkable. Hardly any field of the biomedical sciences has been untouched by this development, and many new disciplines have appeared in the process. The mission of the Convergence Science Network since its inception in 2008 has been to engage the wider public with scientists who share the many exciting advances that will shape the future of healthcare. I'm delighted that today we are discussing a major Australian research undertaking that is a great science story and a great human story, the development of a retinal prosthesis to restore functional vision, or as it is more commonly referred to, a bionic eye. We've brought together a panel who have each played critical roles in the project, and we are super delighted to also have a recipient of the retinal implant to tell us about this life-changing technology. So let me introduce you to the panel. Brian Gordon is the Chief Technology Officer of Bionic Vision Technologies. Associate Professor Penny Allen is a surgeon from the Centre for Eye Research Australia and the Royal Victorian Eye and Ear Hospital. Dr. Matt Pito is a Senior Research Fellow at the Bionics Institute of Australia, and Mrs. Colleen Knowles, one of the 4 Australian recipients of the retinal prosthesis. I'll speak with each panellist in turn. Feel free to use the chat facility to put your question to them. You can continue the conversation by using the event hashtag Bionic Eye and the handle @ConverseEye. Let me now bring in Brian Gordon. Brian, welcome and thank you for joining us. You are the Chief Technology Officer of Bionic Vision Technologies. Tell us a little about your prior career before taking this role.
Thanks so much, Luan. It's really exciting to be here tonight. So as Luan mentioned, I'm the Chief Technology Officer at Bionic Vision Technologies. And so my role really is to take the device through to commercialization. And I look after within our company the product development side, as well as the clinical side of our company. Before joining Bionic Vision Technologies, I was at Cochlear for many years, and I worked on product development there. And so I'm really excited to be at the phase of the project where we can take this fantastic research and then bring it to more people. So yeah, I'm very privileged to have this role.
Thank you, Brian. What were the goals of the project when it was formally announced in 2010?
So this project was kicked off formally, as you mentioned, in 2010 by a very large Australian government grant. And so the purpose really was to help people see. So we really very focused on being able to deliver a product to market. And of course, my wonderful team will tell us all about that journey. But so we want to get something that's out on the market and can help as many people as possible. We want to take people and give them things that are useful to them. So help them do things that they weren't able to do without the product. That's really the primary purpose of the product.
Jumping ahead, can you tell us in, I guess, simplistic terms, how the Bionic Eye system that you and your team have developed works?
Absolutely. So here's a slide that we prepared earlier, just in case you asked us this question. And so basically, the system consists of two components. The first one is an implant, and the implant has an electrode which sits behind the retina in a space called the suprachoroidal space, and it has a stimulator that sort of sits on top of your skull but underneath the skin. And so that's implanted by a surgeon like Penny. And then the other component of the system is our externals, and that consists of a camera mounted on some glasses, a processing unit, and a coil. And so the way that works is that the camera will pick up the images as the patient wears them or the recipient wears them, send those images down to the processing unit. And in the processing unit, that's where the magic happens. So we take all the information from the camera and convert it into something that hopefully is understandable by the recipient of the system. And then we send that through to the coil, through the skin to the implant, and we stimulate the electrode. And the electrode, those electrical signals, then excite the neurons in the retina, and people with the product will perceive that as some form of vision. Not the same vision that we have, a different sort of vision. I'm sure Colleen will tell us all about that a little bit later.
Brian, you mentioned electrodes. How many electrodes does this device have?
So we've got 44 electrodes on this device.
And the device that's been implanted, was that the sort of first version, if you like, or was there a sort of a preliminary prototype that was used to, I guess, make sure the science worked, the electronics and that worked together with fewer electrodes? Is that the case?
Yeah, so of course it was quite a journey to get to this part, and Penny and Matt have been involved the whole way. I'm a relative newcomer just in the last few years, but so of course the first step was the basic science and the concept. So the team worked through that. Then the next step is testing it in tissues and in the lab. And then we need to do preclinical studies to make sure that before it goes into humans that it's safe and that we have a high confidence it's going to work. And so that was obviously a huge amount of work. Then once we were sure that it was safe and we had a pretty good idea that it would work in people, then we ran a study with 3 patients. But that wasn't for a full system. So they could only use that system in the lab. And they had it in for 2 years. And that gave us really good confidence that, this was really something that was going to work. And then following that, then we could move on to this study. So yeah, it's been a really long journey, huge amount of work and lots of achievements.
You mentioned that BV Bionic Vision Technologies, has a responsibility for commercializing the technology. What sort of role and contribution, other than yourself and the team, you've obviously had to attract some funding. Can you tell us how you went through that process and how challenging it was to go to people to say to ask for funding for a project that a lot of people have tried to develop similar systems and technologies before us, and perhaps haven't been so successful. So can you just take us through that journey and what results you've had?
Sure, absolutely. So luckily for me, my job's to focus on the development of the product, because absolutely the funding journey has certainly been an interesting one. So of course we got a really great head start with the government funding, which was part of Vision 2020. So I think that really helped a lot. And the project ran through until and managed to get that first study run completely on that funding. So in 2016, we got another 18 million US of private funding, or about 23 million Australian. And again, I guess the research partners were very instrumental in supporting that funding to be raised and to set up the Bionic Vision Technologies commercial entity. Right now, of course, like any good startup, we are still raising money. So if any Convergence Network viewers feel like this is a great investment opportunity, please do reach out. But yeah, I mean, I guess the funding process means talking to a lot of people and sharing our story, showing the brilliant science that's been done, showing the brilliant clinical results that we have, and really, from my perspective, the route from here to market is far easier than the route from where we started to get to this point. So that's, again, really encouraging time.
Yeah, I mean, particularly encouraging to attract some substantial overseas funding in the project. And I think perhaps the success of that was really, as you mentioned, the top rate science that is behind this initiative. There have been other attempts and continuing attempts around the world to develop similar technologies. What do you think sets your device, your technology apart, Brian?
So I think we've got two really key significant advantages. So the first one really is in our electrode design and in our surgical placement. And of course, Penny will talk a lot more about that, being the one who is really responsible for most of that. But ultimately, that positioning of the electrode means that our device is far safer and far more straightforward to implant than any device that's ever gone before, or to my knowledge is being considered at the moment. The other key area is really in our vision processing algorithms. So we do a whole lot of really cool stuff. We don't just try and send the full set of data from the camera to the patient. We're doing AI and face detection, and we're doing distance measurements. Unfortunately, Colleen doesn't have all of those things yet, but we've actually recently been awarded another grant. It's called the BMTH3 grant for $1 million to further develop our vision processing algorithms. And I'd say, other than the surgery, that's our other key advantage. We've just got some stuff in there that nobody else has really tried as yet.
So, Brian, what are the next steps, though, in making this device more, readily available in Australia and throughout the world? I guess, a true commercialisation of the technology. What needs to happen next to get to that point?
Absolutely. So once we get a little bit more money, we need to finalise our commercial device design, and that's really about taking all the elements that we've been working so hard on and making sure that we can produce it in the right quantity consistently and for a reasonable price. We will then run a pivotal study, and that will be both in Australia, US, and also Europe. And then following the pivotal study, then we will submit to regulators, including the TGA in Australia and the FDA in the US, and also in Europe. So really quite a straight line process from here. There's no massive unknowns, but it is still quite a lot of work, and it will still take us quite a while, about 4 years.
Another 4 years? That's optimistic scenario, Brian. 4 years?
I think we can do 4 years. Yeah.
Great. Look, thank you very much for sharing that important information with us. Very grateful for the work that you and your team in BVT obviously are doing to make this a success. Thank you, Brian.
Thanks.
I'd like to invite Matt Petto now to say a few words. Matt, good evening. Hello, welcome. tell us a little bit about yourself and how you became involved in this project.
Absolutely. Luan, it's a pleasure to be here. Thank you. I'm a senior research fellow at the Bionics Institute in Melbourne, and my background is in biomedical engineering. I studied engineering and a little bit of neuroscience. And during my PhD studies, I worked in hearing diagnostics and then went on to work at the University of Auckland in a neurology research position at Auckland Hospital. And in 2012, when that position was ending, I was very fortunate to learn of the research happening in Melbourne with the Bionic Eye. And at that time, there was already a clinical trial underway with, as Brian mentioned, the prototype Bionic Eye with the recipients Murray, Morris, and Diane. And I was extremely fortunate to join the team at that time and work with those Bionic Eye recipients to learn about how best to optimize the electrode design and how to allow those recipients to use a video camera to perform some functional vision tasks. So that was my early involvement in the project, and that successful trial in the first prototype recipients that begot further funding from the NHMRC to continue with this fully implantable study. And that's the Generation 2 implant that Colleen and others have been using since 2018.
Can you describe for us some of the key features of the prosthesis?
Absolutely. Again, we have a slide that we can show you on the external components there. So you can see as before, the device consists of a pair of glasses that have a camera on them. And that camera is sending a video signal to the external processing unit. And those images are turned into signals for electrodes that are at the back of the eye. And the way that those signals get to the back of the eye is through the stimulator coils on the side of the head. What the system is doing is taking complex images of the real world and making them refined and suitable for the electrodes in the eye. And the basic steps that we follow there is that we simplify the video image to be only a few tones, so black and white and grey. And we also restrict the field of view to match the electrodes in the eye. So the electrodes cover about 30 degrees of visual field, which is considered actually quite large for a bionic eye. The Australian bionic eye has a wider field of view than other ones. And when that image is sent to the electrodes, what is seen by the recipient is like a series of flashing lights. So you can see in this slide here that camera image has been represented as some lights on that far right image, and that's representative of what a recipient may see. The electrodes are stimulating residual neurons in the eye, and it may be seeing fireworks of light that define the basic shape and location of objects. So that's the basic components of the system. To use a system like that requires some training. So part of my role is to optimize the device for each recipient. And I need to explain that at the moment, the best indication for a bionic eye is a disease known as retinitis pigmentosa. That's a neurodegenerative disease of the eye. A recipient is born with useful vision, but over time their eye experiences that degeneration. And what remains after a long period of blindness is enough neurons that can be activated by electrodes, but in a fairly undefined manner. So part of my role is to learn for each recipient which parts of their eye respond and how strongly. And so I probe each of those electrodes using specialized equipment. I work with the recipient to learn about what they do see. And then we try and optimize the camera to match their particular situation. And then myself and the team, we take them through some exercises of rehabilitation. We allow them to touch objects while looking at them with the camera and learn that correspondence between the shape and size of objects and what the camera and the electrodes will tell them about those shapes and sizes. And we also take them through some tasks of maybe walking to a doorway or avoiding obstacles or finding objects on a tabletop. So there were a few months of rehabilitation that the recipients went through. And because we were running a clinical trial, we repeated those assessments every 3 months to learn about whether the system was stable, and whether they were finding it useful for those activities of daily living and for those orientation and mobility type of tasks. And we're really pleased to learn, and I hope Colleen will agree with me, that this device really does enhance quality of life for those visual functions, and allow them greater independence than they may have otherwise had without.
As Brian mentioned, and as we know, this has been a project that's been in the making for a long period of time, relatively. What have been the major challenges in getting the device, ready for clinical trials? What processes had to go through at your team at the Bionics Institute, principally, perhaps with other colleagues, to get the device, ready?
Absolutely. So it's no small thing to have a device implanted in the body. It really does have to pass a lot of safety evaluations to learn that it will be compatible with the body and not cause any damage to those sensitive tissues of the eye. We were really fortunate that the preclinical work was led by Professor Rob Shepherd at the Bionics Institute. And his background is a whole career of working with cochlear implants to evaluate the safety of those devices in hearing tissue. So his leadership allowed us to develop the electrodes and the surgical approach with Penny Allen to ensure that the device was going to be safe to be surgically implanted and also to be have active electrodes in the tissue without causing damage. So the major challenge there was to evaluate that safety, and we're really pleased that after all those that work, the device we have now is incredibly safe and effective.
And you obviously brought, this long legacy at the Bionics Institute, which was previously, many people may not know, called the Bionic Ear Institute. You obviously brought a lot of that know-how to this project as well, right? So that's been a sort of a major advantage or strength that the project has had.
That's absolutely right. Our experience with the cochlear implant translates really well to other devices for the body. So the Bionic Eye is a good fit. We also develop electrodes for other indications such as irritable bowel syndrome or diabetes. So Electrocuticals is the science term we use now to indicate using electrodes for therapy in the body. And at the Bionics Institute, we're able to develop those safely and effectively with our surgical colleagues, with our clinical colleagues in the hospitals in Melbourne and around Australia. And so our expertise, you're right, we really enjoyed contributing to the Bionic Eye program and bringing it as far as it's come.
Can the device be sort of thought of as a part of the family of deep brain stimulation sort of technology devices?
You could say that. So it is. Some people do term it a brain-computer interface because it is interacting with neural tissue and it is conveying information as a visual sense. But it is a prosthesis. It is not true vision that's being conveyed here, but with that visual pathway, it is activating a sense of vision. And with the right rehabilitation, that sense of vision can be useful.
Matt, what can you tell us about the team and the skills that the team had in developing the device? How diverse was the team's skill set?
Absolutely. So we're a multidisciplinary team, and probably what unites us is that we're passionate about clinical outcomes and the clinical sciences. But the background of people that contributed to the Bionic Eye is as broad as engineers, clinicians, ophthalmologists, surgeons, but also computer vision experts. we've had on our team Professor Nick Barnes at the Australian National University, and his team at various times at Data 61 and CERA. And the University of Melbourne has been a contributor with their engineering department. So we've had a very broad team come together, and we've really, I wouldn't say we've stood on the shoulder of the giant so much as we've been really unified in our teamwork here. It did take a lot of people's contributions to bring this all to where it's come to, and everyone played a really major role, no matter what their background and contributions were.
I can imagine, and I know why you get up every morning and want to get off to the lab and continue the amazing work that you and your colleagues are doing. Matt, thank you for that overview and appreciate everything that you and the team at the Bionics Institute in particular are doing. So thank you for that.
It's my pleasure. Thank you.
We're going to get on to the surgical aspects, and I'd like to invite Associate Professor Penny Allen to say a few words. Penny, welcome. Hello. Thanks for joining us. Will you share with us some of your background before you got involved in the project? Tell us a bit about your career and expertise.
Well, thank you, Luan. Thanks for having us on tonight. It's lovely to be here and to be able to speak about this project. I'm what's known as a vitreoretinal surgeon. So I'm an ophthalmologist who has then subspecialised in retinal surgery. I grew up in Geelong. I went to Melbourne University to do my medical degree, and then joined the ophthalmology program at the Royal Victorian Eye and Ear Hospital. Subsequent to that, I trained in vitreoretinal surgery, both in Melbourne and in London at Moorfields Eye Hospital, and then have continued to work in Melbourne. I'm a principal investigator with the Centre for Eye Research Australia.
Thank you, Penny. I think Matt mentioned the device is really targeted at the retinal. Sorry, I forgot, Matt, the specific.
That's retinitis pigmentosa.
Retinitis pigmentosa.
Correct. Thank you very much.
Yeah.
Does it apply to other retinal conditions as well, Penny? So is it just retinitis pigmentosa that we're talking about here? Because there are other retinal conditions, as well.
No, this device is specifically applicable for this form of inherited retinal disease, which we call retinitis pigmentosa. It's really an umbrella term for a number of different mutations, usually within the photoreceptors of the eye. So that, as Matt mentioned, patients are born with vision, but they then progressively lose vision, usually during their school years and early adult life. There's more than 250 different mutations within the cells within the retina that can cause retinitis pigmentosa, and it results in a loss initially of peripheral vision and night vision as we lose the rod photoreceptors, but then later, as the vision loss comes in, then the central retina is affected as well, and we lose cone function, and so then lose colour vision and fine central vision. There are some variants to this, but I think the way to think about this is that if you were walking down the street and you saw someone who had a cane or a guide dog, then the most likely diagnosis that they would have is retinitis pigmentosa. It is the commonest cause of visual loss in working age people now.
We have a question from Bronwyn, and I think you may have answered this. And Bronwyn asks that this device would not be helpful for retinal detachment.
No, it would not. As we lose the photoreceptors in inherited retinal disease, in retinitis pigmentosa, then there are residual neural elements that are left. The retina is essentially a 10-layered structure, and it is those residual neural elements that the electrode array stimulates to produce the visual impulses that we call phosphenes. Retinal detachment now is treated with surgery, and in fact, retinal detachment surgery is in fact very successful.
Okay, great, thank you. Look, you've been critical in the project in determining, the design of the device. Can you share with us what were some of the challenges in developing the prosthesis from a surgical perspective?
Well, I was very lucky to work, very closely with Professor Rob Shepherd, and from the Centre for Eye Research Australia, Professor Robin Guymer, who was the clinical lead at the time of Bionic Vision Australia. We needed to design an array that would be stable within the eye and obviously safe. The eyes that we are implanting obviously have very poor vision, but nevertheless, it was very important to us that this device be safe and stable. And hence we used a different surgical approach, which we developed from the bench through work in cadavers at the anatomy school at the University of Melbourne, and then into our initial prototype trial. And our initial 3 patients, as Matt mentioned, Di, Murray and Morris, were just absolutely vital to the development of our Generation 2 device. They then gave us feedback regarding the visual impulses that were produced from the prototype device, and offered suggestions about how to make the device more useful to, widen the field of view, both horizontally and potentially vertically. Obviously, to be able to use the device outside the laboratory. And, these were challenges that we obviously had to overcome.
How big is the device, Penny, that's implanted in the eye? What are the dimensions?
The intraocular component is about 19 millimetres by 10 millimetres.
Right.
So it's a silicon sheet that has the platinum electrodes implanted within it.
What criteria did you use to, select the patients who may have been suitable for the clinical trials?
We needed to start with patients who had lost navigational vision. The intent of the device is to try and aid patients with navigation and object identification. Professor Robin Guymer collected a database of patients with inherited retinal disease, and we are still collecting patients for that database at the Centre for Eye Research Australia, with a view to, further trials, not only of bionic devices, but gene therapy. We needed patients who were obviously very altruistic. They were essentially volunteering for a trial for a device that we initially couldn't be sure that it would produce phosphenes within the eye. Because this is an inherited disease, then a number of our patients have relatives that also have the disease, and they are a very strongly motivated group, and just an essential part of the research team.
I've got a question here from Danielle Penny, and the asks how's the device sort of, if you like, interact with the brain? Does anything actually go through the eyeball?
Well, the electrode array is implanted beneath the retina, and then the stimulation of those electrodes, and we can see the electrode array in the upper image here. We can see the lines of the small electrodes, which are the stimulating electrodes. The two larger electrodes are what we call returns. On the right, we can see a black and white image of the array beneath the retina. And below, we have what we call an OCT scan, which demonstrates the position of the array beneath the retina. So the electrical stimulation is delivered. The residual neural tissue of the retina is stimulated, and those impulses pass via the optic nerve back to the brain.
Thank you, Penny. And after the procedure and the rehabilitation, how long does it take for the patient to actually have some or regain some functional vision?
Well, the initial stimulations we commenced 2 months after the patients were implanted, and that's when they started working with Matt in the lab at the Bionics Institute. Switch on day, which I'm sure Colleen will talk to you about, is obviously the day where we determine that actually visual thresholds, the stimulation is sufficient to generate a visual perception in the eye. And then Matt works on tailoring the stimulation to each individual patient, and then starts with the identification of objects and the various testing and training in orientation and mobility.
So what have been some of the key results that have come out of clinical studies? Things that really have been major results, major findings.
Well, we've been extremely happy with the safety and stability of the devices, that it's a straightforward surgical procedure to place the device beneath the macula, the central area of the retina. The devices stay stable for more than 2 years of implantation, and we haven't had any serious adverse events either related to the device or at all during the study. And then all 4 patients were able to perceive phosphenes and then complete a number of these tasks of mobility and orientation and tasks of daily living, trying to identify washing, things that really Colleen should talk to you about.
Before we get to Colleen, I just want to ask you about some recent reports that have been in the media about gene therapies, and perhaps as a way to treat vision loss. Can you tell us a bit about that? And is that something very different to the type of technology we're talking about? Are they really treating different types of diseases or patients?
No, they can. The idea of gene therapy is to introduce often via a viral vector underneath the retina, so via an injection underneath the retina, to try to correct the genetic abnormality which causes the loss of vision in patients with retinitis pigmentosa. The issue is that, unfortunately, that there have been at least 250 different genetic mutations identified thus far. And so a gene therapy needs to work to correct that particular mutation. At the moment, there is only one commercially available gene therapy for a form of RP that occurs in about 1 to 2% of patients that are affected by the many, many different mutations.
So there's a long way to go, obviously.
Yes.
Clearly, in the course of the project, there would have been many ethical issues that would have been raised. How did you go about dealing with the ethical issues?
Well, we obviously, all of these trials have to be submitted to a human research and ethics committee, but I think that for me, the true you have to actually feel that you are doing ethically the right thing by the patients before you would even submit to an ethics committee. It's not something that, you know, and that's the great thing about this team, is that, as Matt mentioned, we've all been very focused on patient outcomes. And that has meant everything from choosing the materials that were used for the development of the device, you know, choosing materials that were safe, had been used before, making sure that our evidence that the devices were stable before we even went into cadaver studies, making sure that all of that work was very thorough and methodical. We pull all of that together so that when we initially speak to the patients about a study like this, we need to be confident that we can answer their questions very thoroughly. We need patients that understand the surgery, and we need to explain exactly what the trials involve. There's a lot of different aspects to it, and luckily, I think our team have approached all of that in a really thorough and collaborative manner.
Thank you, Penny. Your comments have generated a few questions. If you don't mind, I'd like to put some of those to you. Milena asks essentially about the stability of the device, and does it have to be replaced every 2 years? There was some comment earlier about having to replace the device every 2 years. I guess the question is, what's the lifespan of this of the device in the future? Ideally, is it something that you only need to have one procedure, or what are your thoughts on that?
Well, the array was designed to be left within the eye, so that there's no need to replace it after 2 years. Really the benefit of this device is that with the vision advances in vision processing, so that is the externals can be upgraded and still just utilize the device that has been placed, the receiver stimulator that is on the skull and the device within the eye. We did do preliminary studies looking at removing a device and replacing it if that would be necessary, and it is possible to do that, but that is not something that is planned.
Thank you. Another question from Bronwyn. Could the device be helpful for image result for, is it Stargardt disease as well as retinitis pigmentosa? Did I say that correctly?
Stargardt's, yes.
Stargardt
Stargardt's disease is a form of inherited retinal disease. However, predominantly the visual loss is central, and most patients with Stargardt's disease do not lose navigational vision. They will lose facial recognition and the ability to read, but they can usually navigate independently. And at the moment, the results that we have from our device are really more for orientation and mobility.
And finally, a question regarding the applicability of the device for people with glaucoma. Is that a possibility?
No, unfortunately, glaucoma affects those neural elements within the retina that we need to stimulate to produce phosphenes. So unfortunately, glaucoma this device is not applicable for patients with glaucoma.
Penny, thank you very much, and again, congratulations on the the incredible work that you and your team at the Royal Victorian Eye and Ear Hospital are doing. I'm sure you and others are training many other people to perform these tasks in the expectation that the device will be more widely available in the years to come. And you've been with the project, with the team from the very beginning. So again, it's worth mentioning that significant milestone. So thank you, Penny.
Well, thank you, Luan. I won't take that as making me feel old, but no, thank you. It's great that everyone's interested in the project, and I've had great support from my fellow surgeons at the Royal Victorian Eye and Ear Hospital, and our clinical team at CERA have also been together for a long time.
And it adds to, again, as with the Bionics Institute, it adds to the global reputation of the Victorian Eye and Ear Hospital as a major centre for procedures, operations for the ear, the bionic ear. The Graham Clark bionic ear first procedure happened there, and the first bionic eye procedure happened there. So it's quite a bit of history and legacy again in the hospital. So thank you. I'd now like to welcome and introduce Mrs. Colleen Knowles. Colleen is one of the recipients of the retinal prosthesis, and she's very kindly agreed to participate in this event, and we're delighted she's with us. So Colleen, hello, and how are you? Colleen, hello.
Hello.
How are you?
Yes, we've had a few reception problems here, but we'll do our best.
No, you're coming across very well. Thank you.
It's great to be a part of this.
Colleen, can you just give us a bit of background, who you are, where you grew up and that sort of thing? Tell us a bit about the Colleen that we don't know.
Okay. I was born in Albury in New South Wales. I've always had poor vision over the years. In another couple of weeks, I'll have been married for 50 years, so that's a personal milestone. And I am a great-grandmother, and my family is very, very important to me. I have an interest in social science, so I have a degree in social science because I have an interest in people, what makes them tick, why do they think the way they do, and so on. And also I have a love of history as well, and that's why I became involved in this, was part of being part of history, because it's certainly history making and quite a coup for Australia as well.
And can you tell us, please, the circumstances regarding your loss of vision? How and when did that occur?
When I was a child, I was able to wear glasses that gave me some time. My parents didn't know that I had vision problems. They thought I was just clumsy because I run into stuff and fall over and things like that. And then eventually somebody, after I'd been at school for about 6 months, obviously I couldn't see anything on the board, but I was painfully shy and just thought, well, that's how everybody else sees. So anyway, they eventually suspicious and had a lot of tests and things done. And as I said, the glasses did give me some. With my particular retinal condition, it's actually the reverse. I lose or have lost most of my central vision, and the periphery area is the last of it to probably finally go. So I've got the reverse of the usual RP prognosis. Either way, you still don't see much. By the time I was in my early 30s, I couldn't find any usefulness for the glasses. They were no longer, to the point that I wouldn't even realise I had them on. So they'd gone as far as they could down that area. So I just stopped wearing them. Now, I don't really see anything. I have light perception, daylight or nighttime, that kind of thing. And yeah, so that's probably where I am at the moment. So there's no central vision at all, but there is a smattering of little bits of light perception happening around. That it's probably where I am in the natural at the moment.
Colleen, how did you find out about, the Bionic Eye project, and why did you want to be involved?
Well, I got involved because of the history side of it, but also I've had a personal interest in any improvements in any eye condition. I think it's an exciting be alive, various types of conditions. I heard a talk about the first trial, and I actually started to inquire into it. Then I had news that my father only had a few weeks to live, and of course I was very upset by this, and I felt I couldn't give the trial the involvement and the commitment that I felt that it needed, so I withdrew from that. Then I heard another talk about that they were looking at doing a second trial, and I investigated into that and had some interviews and things, and yeah, the rest is history.
And obviously you had your family was very supportive about your participation.
Oh, absolutely. They've been wonderful. Absolutely. Been fantastic all the way through. I'm really blessed there.
Yeah. Tell us, when was the procedure performed? How long have you had the device implanted?
We're coming up to three years, I think. I don't know. Wow. I've lost trace because COVID.
And before the procedure, was there any special sort of rehabilitation or any preparation that you needed to go through, Colleen, to get ready for the procedure?
Restrictions. So it's well, there were a couple of interviews initially, just to make sure that I could understand what I was getting involved in, make sure that things were, and also I guess the panel needed to be sure that they were going to get some commitment to the whole process, because you don't just step into it and then back out, or unless you've got a really good reason. Conducted to see the back of my eye looked and so forth, or the optical areas that they needed to know about. And a few weeks from memory before the surgery, I had an assessment done by a psychologist, again, just to make sure that I was comfortable with everything, you know, and ask any questions, any concerns I may or may not have had, all of that kind of thing as well. And I must have said all the right things, because I've been a part of it ever since.
Are you able to share with us those first moments after the Bionic Eye system was turned on? What are your recollections about what happened at that moment?
Yeah, I think it was about 8 weeks after this. It at the Bionic tube, so I was connected up with the device, and all of that was connected onto Matt's computer. My family and Penny and I think a couple of other people were in another room observing everything by CCTV. When Matt clicked on to, was on his a sound, a beeping sound, and then hopefully that sense of a flashing sensation. There was nothing happening, and I was getting a bit discouraged, but Matt was tweaking the setting forth, and then all of a sudden, out of the blue, I saw a flash. Now, general public might think, oh, what's a flash? For someone who can't see anything at all, normally have
it's an amazing moment, something that obviously
testing whether I could find objects on the table, running doorways, all of that kind of thing, obstacle courses. I learned to interpret what that flashing was, and able to have some functional use from it. So it depends on whether they're bright or blurry or just a flicker. They might be a long, narrow streak. They might be just irradiating like the sun coming up from behind a hill. It might be very small. It might be just a very quick flash, or it might be sustained. And by learning to interpret what those flashes were indicating to me, helped me to interpret what was happening around me in my environment. Because normally, if there's no verbal cues, I have no idea what's going on. So it was very exciting, that initial, when the first one, I remember going, ooh, because I got such a delight from it happening.
You have a device with you, and you've agreed, or you're very happy to
Yes.
Put it on, wear it, and so that we can see the device. Would you take a moment to do that, please?
Yeah.
Thank you.
Sure. So can you see that from there?
Yep.
So I've got
the glasses.
They just look like ordinary glasses. They're quite stylish glasses. So I pop them on. The camera is actually here on the right-hand side. And, whoops, they got entangled in my earrings. I have the electrodes, what do you call it, the coils, and they actually connect to the side of my head, where that implant is. Okay? Then you've got the cord. At the end of that is a little magnet, and this is the processor. I normally have that, it's on a belt, and I normally have that around my waist. I think some of the participants are wearing it around their neck, some over their shoulder, and so on. But for me, I find it comfortable to wear it around my waist. On the side here is a little indent, and I just get in there. Helps better if you don't have it in reverse. Just clips on there. Push the on button down the bottom there, and that's made a beeping noise, which means that it's functional and it's working. Within about I will be able to see some indicating to me that the device is working. So the top button here is for indoor mode, light coloured objects, to help me facilitate that. So around the house, that kind of thing. The next button down there is for outdoor. We've clicked on now, so it's actually bringing up some indication of what's around in my area. You're actually flashing heaps on that screen, whereas before I couldn't even tell that the screen was there, whereas now I'm aware of it. So the outdoor mode is picking up dark objects such as plants, trees, people, buildings, that kind of thing. And then the bottom button is just simply a pause button. And I can interact between the different settings anytime I wish. It happens automatically. So if I've had it on indoor and I'm about to go outside, I can just do a very quick flick and it will change it immediately onto outdoor. Or I might have it on outdoor when I'm out and about and I'm about to go into a shopping complex. Then because I'm indoors, I may switch it back on to the first setting. But then with shopping centres, it's a bit of a variable. It depends on how well lit they are, how much natural light is getting in as well, if they've got a skylight, that type of thing. But you just kind of play around with the buttons and work out what works best for you.
I guess when you're out and about shopping, do people come up to you and sort of say hello and ask you what you're wearing and you know, what you can see? Do you get that interaction from the general public, Colleen?
We're having some reception difficulties here. Are you able to repeat that? Are you there, Luan?
We're just repeating, Colleen, about the general public. Do they interact with you and see what you're wearing?
Generally not, because it's rather, apart from this being around my waistline, it's relatively inobtrusive. I mean, no one goes up to somebody with a cochlear ear implant, and I believe they have a similar type of device on the side of their head. I have occasionally had an odd taxi driver ask me about it. What's it all about? Why do I have that device? I guess if the surgeons were going to pick up anything, I was not aware that I would have quite so much of my hair shaved off. They left me with a lovely little sort of quarter patch on my scalp that I wasn't quite prepared for. And I got in a taxi one day and lovely new Australian gentleman said to me, "What have they done with your head?" So, you know, but generally speaking, no, the public haven't really said anything, except those who know me and know that, you know, I'm wearing it, and they might ask some questions.
And what about your guide dog Freeman? Does he have some time off now? Are you able to navigate without him successfully?
No, I'm working. It for me in my particular situation. Now we've had 4 participants take part, and each of us at different levels of visual ability. I'm the only one with a guide dog. Someone else uses a white cane. We've all got the same device implanted. We're all individuals and we all have different abilities. So Freeman and I actually work together as a team, and he's keeping me going from A to B because he understands, if I tell him to find a certain area or whatever, he understands what I'm asking him. And the device, for me, it gives me an awareness of what's happening in my life, what's around me, what are my surroundings, are there trees, am I in a garden area, am I in the CBD? I love it when I'm inside a shopping complex. I'm observing people all again. That probably comes back to that love of social science. Just to sit and watch what people are doing, where they're going. Are they turning into a shop? Are they pushing a shopping trolley or pram? I've been able to generally detect, or whether it's just one person going past or two or three in a group, that kind of thing. Sitting in a cafe, there are other people in that cafe around me. Without the device, I have no idea unless they're all chattering loudly. Whereas this, I can just sort of look around and be aware that there are people close by. Yeah, I just love the sense of knowing what's going on, what's around me, kind of thing. It just helps me feel a bit more a part of the community than people take more notice of the guide dog than anything else.
You're connected in a very, very real and a very different sense, and a very profound sense as well, Colleen. And I guess it must be really, really special, to be able to have your family around and know that, that they're there, and to see them as well as you can. That must be really, really something that you cherish.
Just and to see grandchildren playing, watching them in the backyard of their home, that kind of thing. Whereabouts they are. One of the big kicks that I got out of my venture was normally in the enclosure or in the paddock, and with the device on, I was able to sort of scan around and pinpoint where the elephant or the giraffe or zebra or whatever it might have been, where they were actually standing. And if they were moving, I could actually track where they went and how they, from one side of the enclosure to the other, that kind of thing. And it just enhances the whole experience of living.
And you must feel a great deal of excitement, when you're waking up in the morning. Your life is just so different now, isn't it?
Yeah. No, it's a lot depends on what I'm actually planning on doing with my day. For me, and again, it's only an individual thing, I find it more functional for me when I'm away from my home, because I live in a unit now, and it's quite cozy and perhaps and a bit on the darker side, so it's maybe not giving me as much scope as it did from home. But when I'm out and about, yes, definitely makes a huge difference. Even here, like I'm living in a retirement village, just navigating my way around, and yeah, it's really good.
Colleen, thank you very much for
where I used to walk down a particular street all the time. I never knew that there were a whole lot of trees in that street, in the nature strip. And the first time I went outside with the device, it was just, it was a little bit overwhelming initially to know that there were so many trees just in that I'm able to participate in and enjoy.
Colleen, thank you very much. I mean, it's truly life-changing. And I think the team, the panel, the other members of the panel, must feel very, very, very proud of, their achievement. Can I throw back to the other members of the panel, and you've seen Colleen's progress. What does it mean to you to hear her talk about the device, the technology in that way? Penny, can we start with you?
Well, there's obviously a huge sense of achievement. It's been a long time and a lot of work, and a great team. And after the first trial, I really thought that all 4 participants in the second trial, I believed that they would have some phosphenes. I didn't know how useful the device would be, but obviously I couldn't say that when we were doing the consent before the surgery, and it's wonderful. It is a really wonderful to hear Colleen's comments about the device, and just because we can't always predict in what way it will be helpful, and as Colleen very rightly points out, each patient and each participant is an individual, and they utilise the device in a different way. And there was no way that prior to this that we could have predicted all of the ways that would be utilised.
Matt, how do you feel?
Oh, look, it's actually really thrilling to hear of Colleen's achievements there, and it's really made the whole project extremely fun to come to work and work with people like Colleen and go through these achievements together. It's been fantastic, and Colleen, look, it's been really thrilling and fun to work with you, and I'm really pleased that that you're appreciating and getting that benefit to have that social engagement. In particular, the social engagement is really really thrilling for us to hear about, and really what we wanted to achieve. So we're very proud and satisfied that our nerdy efforts at the computer screen have paid off to actually give a real world benefit to other recipients.
Thanks, Matt. And Brian, I guess, while the job's not done, it hopefully makes your job a little easier, having that sort of testimony from Colleen and others, hopefully.
Yeah, absolutely. I mean, I was lucky enough to join after Colleen was already implanted, and I'm so grateful both to the research team for taking it this far, and of course to Colleen and the other recipients for volunteering and taking this risk and pushing things forward, and also for giving us all this amazing feedback on what works well, what doesn't work well, what do we want improved, and that's really an amazing thing that the recipients have all done for us.
I think, Luan, if I could make one other comment, is that all 7 participants in these trials are just as much part of the team as Matt and myself, and we couldn't have done anything without them. They're all such hard working. They've been so motivated. They've been devoted to the project, and it's been as Matt says, it's been fun. We love the team, and and we've all really enjoyed working together.
Shouldn't we be shouting from the rooftops? Does the rest of the world know about what's going on in Melbourne and with this project, or is it too early?
Look, we take our achievements to conferences overseas, and the world is definitely watching. Our implant's very unique in how simple the surgery is and the profound benefit it can give. So that's where we look to Bionic Vision Technologies to be the vehicle to get it out to the masses. The evidence is there. We've got a story. We've got a product. Let's go great guns from here.
Well, I mean, look, really, as we've learned this event today, this project has had a long gestation. Maybe not uncommon for, complex projects where you have biology and engineering converging. But I hope the audience agrees with me that it's been worth the wait. I think so. So I want to congratulate the team on this remarkable and profound achievement. It's been made possible by a strong legacy of investment in education and research that's given local scientists the quiet confidence to tackle, this very complex challenge. And Melbourne's very fortunate to have leading research universities and clinical expertise, institutions such as the Bionics Institute and the Royal Victorian Pioneer Hospital, and a successful track record in the development of the bionic ear that have really come together to make this result possible. And all of this has been underpinned, as we've seen this evening, by a high spirit of collaboration among scientists and institutions. So I'd like to close this event, again, to thank the panel members, Penny, Alan, Brian Gordon, Colleen Knowles and Matt Pito, for their commitment to share this exciting Australian science and human story, something that we can justly be very proud of. And as well as the panel, there are a number of other people that need to be acknowledged who have made a contribution for this event. Janine Sim-Jones of the Centre for Eye Research Australia, Joe Crouston of the Bionics Institute of Australia, Tracy Spicer for Bionic Vision Technologies, Maria Kolick, Clinical Trial Coordinator at the University of Melbourne and assisting Colleen this evening, and Colin Leask for Corporate Video Productions. I'd like to acknowledge the incredible support of the Convergence Science Network sponsors for their commitment to public engagement with science. Events such as this would not be possible without their generous support, so I thank them. Please use the link below to take a moment to complete an anonymous survey. Your feedback's important to us, and it ensures that we continue to deliver informative and worthwhile events such as this. And last but not least, a thank you to our audience for giving us your time and for your interest in what we've had to say this evening. I hope you found it informative, inspiring. Consider subscribing to the network if you haven't, and stay in touch with us as we enter 2022, and whether in person or online, our promise is to continue to bring you the people and issues who are shaping the future of healthcare. Until next time, thank you and goodbye.